Good morning, everyone. My name is Dr. Sanjay Prabhu. I am a staff pediatric neurologist at Boston Children's Hospital, and I'll be speaking to you about the role of imaging in pediatric epilepsy surgery in the era of stereo EEG. This is based on nearly 12 years of experience now working with the epilepsy surgery service at Boston Children's Hospital as the lead epilepsy radiologist, and we've been doing stereo EEGs since 2015 onwards. I have no disclosures. So let's talk about epilepsy. What's the definition? It's clinically diagnosed after more than two or more unprovoked seizures, more than 24 hours apart. It's seen in about 150 children, less than 10 years of age, the highest incidence in about in the 1 year, less than 1 year of in the first year of life. Up to 30% of patients with pediatric epilepsy are refractory to medical therapy, and persistent unprovoked seizures, despite trials of more than two medications, is termed as drug-resistant epilepsy. And these repeated seizures can cause brain injury and have an adverse effect on development and behavior. In these patients with drug-resistant epilepsy, the highest rate of seizure freedom comes from surgical resection of the epileptogenic focus. So it's imperative that we work up these patients, find a seizure focus, and resect it if possible. Preoperatively, the idea is to identify structural lesions as the cause of seizures. And we talk about what these are, localize the epileptogenic activity, see if it's coming from that particular area, describe the anatomy for surgical planning, which sulcus, which gyrus is in, what's the gyrus involved, which sulcus is closest to it, what kind of functional areas are there, where is the speech, motor, vision, etc., in relation to the seizure focus. And then we also do a CT angiogram if you're doing stereo EEG for planning of the electrode trajectories. In the postoperative period, imaging plays an important role in identifying surgical complications, including infarction, hemorrhage, infection, hydrocephalus, and other complications. As mentioned here, this can be either in the intraop, so we have intraoperative MRI, which is utilized soon after surgical resection to also look for complete resections. And then subsequently, if the patient continues to have seizures, you can do another MRI at different time points to look for residual potential epileptogenic tissues or incomplete disconnections. So what are we trying to find? In children, the most common substrate for seizures, pediatric epilepsy, is cortical dysplasias in about 42% of patients. Then it's tumors. Then you have etiologies like perinatal strokes, and then some uncommon etiologies include things like cavernomas, plasmacytosis encephalitis, Sturge-Weber syndrome. And it's very important to remember that in some series, for example, this one by Simon Harvey in 2008 from Melbourne, the dual pathology was seen in about 5% of patients with cortical dysplasias and hippocampal sclerosis categories. So these patients can have more than one dysplasia. Patients with hippocampal sclerosis, for example, can have lobar dysplasia in addition to the hippocampal sclerosis. So the assessment is typically a 3 Tesla MRI in our hospital. We very seldom use the 1.5 Tesla scanner. Most of epilepsy patients, almost all of them, are 3 Tesla MRI. We even have VNS safe coils for patients with big and low stimulators to undergo a 3 Tesla scan. Contrast is only reserved for suspected tumors and defining vascular anatomy, so we do not do contrast on a routine basis. We do an interictal FTG PET in some patients, which is fused to the MRI, an ictal and interictal SPECT, and then subtracted to overlay it on the MR, functional MRI, a MEG, and then in the postoperative period, we do either CT or MRI, as I mentioned, to look for complications. And again, 3 Tesla MRI is repeated if the persistent seizures after a surgical procedure. Our epilepsy protocol is as follows: a volumetric T1, axial T2, thin section, coronal T2 of the entire brain, making sure we cover the occipital lobes. This is important. Unlike adults who have mesenteric sclerosis, as I said, cortical dysplasias is the main substrate in pediatric patients, and you want to image the entire brain if possible. Axial T2 flare, FATSAT, and then the sagittal T2. This is a 3D flare sequence with the coronal and axial formats, 1 millimeter slices. Axial diffusion, typically 30 direction or 90 directions, depending on the stage of if it's a preoperative or just routine procedure, routine MRI, and then axial SWI to look for things like tuberculomas, cavernomas, any calcifications, tuberous sclerosis, calcification, etc. Decision making is done in a multidisciplinary setting with the neurologist, neuroradiologist, neurosurgeon, neuropsychologist, and a bunch of other specialties involved. So the question first is, are seizures resistant, and what medications have been used? And or if the medications have been used and there's more than 1 to 3 years of post-seizure control, then they go on to have a phase 1 evaluation where the patient comes in for video EEG monitoring. The seizure semiology is documented. MRI findings are reviewed again, and I usually review the MRI findings at this stage again with the video EEG and the seizure semiology in front of me. Then we also work with other specialties, like I said. If these results suggest that the surgery is an option, then we get additional testing, including fMRI, magnetoencephalography, a MEG, a transcranial magnetic stimulation to map out things like the motor area. Like I said, we do SPECT with ictal and interictal SPECT, PET, source analysis to look for seizure generation areas, and genetic testing. Connected to analysis is also undertaken in some cases. At this point, we ask the question, does surgery outweigh the risk of functional impairment? If there's a seizure focus and it's an eloquent area, and the patient or the parent do not want to see any seizure, you don't want to see any functional reduction, for example, hemiplegia or loss of some part of the vision, then the surgery may not be an option. In the cases where the imaging and the clinical information is discordant, it's a different lobe, or you have multiple areas of involvement, this is the point where we undertake either stereo EEG, which is most common way of invasive monitoring now. A few years ago, we used to do splits and strips more often. We don't do those very often now. Then again, we ask the same question: does surgery outweigh the risk of functional impairment? And if so, we go into do a lesionectomy or a disconnection or ablation. Key point is that we do multimodal fusion images in a single frame of reference, which aids in improved surgical planning. So we overlay the MRI abnormality, the fMRI area of motor activation, language, and TMS and MEG results on the same 3D image to help define the lesion in relation to the functional anatomy. Some key things as preoperative imaging list, you want to make sure, first of all, define the lesion. Are there one lesion or more? Is there a diffuse lesion? Look at the lesion margins. Correlate with seizure semiology, like I said. Look at the relationship of the lesion to functional eloquent areas. Is there another lesion? Specifically look at the contralateral hemisphere. And are the imaging and clinical findings concordant? And then you want to look at any specific surgical landmarks and review the electrode implantation plan for stereo EEG. Look for things like calvary or skull base anomalies, any bone thinning due to previous surgery, etc., because the electrodes have to go in through the skull, and this may make a difference to the surgeon's plan trajectories. Any big emissary veins or spinal encephalocele should be marked at this point as well. Look for any landmarks, things to say, here's a specific sulcus or a gyrus which marks the dysplasia. Any large cortical veins like the vein of Labbé, if that's a marker for where the lesion is. I mentioned this in your report to the surgeon. And look for anatomical variations like vascular anomalies like azygous anterocerebral arteries, which is very important landmark for callosal resections or callosotomies. And then any vascular issues like aneurysms, varices, and in Sturgeon syndrome specifically, map out the leptomeningeal angiomatosis. In advances have in the imaging over the last 10 to 15 years have really made it possible to define dysplasias better. This is a patient who had a scan way back in 2000, was called normal, had right frontal seizures, had a couple of scans in 2004 and 7, were also called normal at 1.5 Tesla scans. And the patient came in for another scan in 2009. I saw this patient then and thought there was some cortical thickening here. This patient could not get a 2 Tesla scan because at that time we did not have a VNS, a vagal nerve stimulator safe 3 Tesla coil. So we got the patient back for a PET scan, which was also abnormal. And then we imaged the patient in 2009 with some thin section images on one bioprocessor scanner with the two echoes, two necks to increase the signal to noise ratio. And he did have a cortical dysplasia here, which was then investigated with subdural electrodes, grids, and strips at that time. And this was resected partially, but there's a small part of the lesion which was left behind because it was close to the areas of motor function on stimulation in the OR on ECOG. Subsequently, 2019 patient came back and was shown to have increased seizure frequency, and we saw that had a residual lesion here. So lesions learned in the initial few years that I was doing epilepsy imaging was the meticulous image technique is important to visualize and diagnose lesions. It's important to raise the awareness of frequency and appearance of FCDs. Technological advances do not always translate to improved patient care unless you actually put the effort in to improve the imaging in these patients. And it's important to constantly keep improving your imaging acquisition. And the radiologist and clinician awareness can help improve outcomes. And this is what we've shown in the last few years. And then lesion detection is only one aspect. You want to see if it's concordant with the semiology, functional imaging, margins of the lesion, etc. And patient benefit versus risk is very important in every case. Then we come to another case here. This is a patient with left frontal seizures. And the initial couple of scans were called long 2000. And then she had a scan where the PET was abnormal. And this PET, you can see, had see if we can get that working here. There was a hypermetabolic area here in the frontal lobe. And the patient came back in 2015 for another scan. And this time, because the PET was abnormal, we did some high resolution scans with 1 millimeter thickness. And you can clearly see that there is dysplasia here in the frontal lobe. And I call this the finger thumb sign. You put your index finger here in the gyrus rectus and your thumb in the lateral frontal, inferior frontal cortex here. And you can see this gyrus rectus is very abnormal. It's almost like your index finger on this side is the thicker area. If you put your index finger on both sides, you can see the asymmetry there. Same thing, you can see the same abnormality here on the axial images here. See if it plays. Probably won't. Okay. So then you can see the abnormality here. So this patient, yeah, you can see that displays quite nicely here. So this patient went on to have a surgical resection of this site, this gyrus rectus and the lateral inferior frontal cortex here, and was seizure-free for the last 6 years. So these are lessons learned in the second phase of improved imaging was these patients with focal persistent epilepsy will benefit from dedicated imaging, and accurate localization of epileptogenic focus correlates well with the success of epilepsy surgery treatment. And lesion delineation should include definition of the margins of the lesion, eloquent cortex, and this is an important substrate for the other modalities that we scan the patient with. And then we have the new era of stereo EEG in the last few years. These are electrodes which are placed stereotactically into the brain, very tiny millimeter-sized electrodes, and they can be diagnostic and therapeutic because some of these electrodes you can also thermoablate to some of the electrodes. We tend to use laser ablation. And the increased incidence of post-op edema with increasing number of electrodes. So imaging can help minimize the electrode numbers by saying, here's the most likely area of a seizure, onset, by saying here's an abnormal area on imaging. That's one of the important roles of imaging in the stereo EEG era. And it also is a navigation map for the surgeon. You also want to make sure that the leads are not touching, as this will confound the EEG data. And on the CT that is done soon after placement of the stereo EEG, you look for bent or broken leads. Once the CT is done, I overlay the CT on the MRI to create this composite map. So you can see where this lesion is. For example, these are periventricular white matter changes with some cortical thinning. For example, this stereo electrode is going through there. And this is our experience for the last few years. This is published recently in Journal of Neurosurgery Pediatrics. So this is a patient who was a 5-year-old patient with the left posterior temporal seizures. Notice this area of cortical thickening in the left posterior temporal, lateral temporal area here, extending into the parietal lobe. You don't see the higher slices. They had covered this densely with some stereo EEG electrodes, and then the electrode, which is the most thickest part of this lesion, was very abnormal, and this was resected, as you can see here, and the patient was seizure-free. The pathology was surprisingly a ganglioma, and I think because the sulci are smaller here, we did suspect a low-grade tumor, which is why I suggested open resection. And this patient did have a BRAF negative ganglioma, but the patient is seizure-free now after 2 years. This patient had a laser ablation of a lesion, which was suspected here in the insula. You can see the normal white matter in the right insula here. On the left side, there was some area of subtle blurring, which suspected. You can see it on the coronal as well, right above here in the insular region. You see this normal white matter on this side. And on this other side, you see some cortical thickening. There was another area as well here along this sulcus. This is I think the precentral sulcus, and you can see some blurring. But this area in the insula was the one which was the most active on stereo EEG, and that was ablated. And the patient has a reduction in the number of seizures post-procedure. This patient is an 88-year-old patient with left frontal cortical dysplasia, and this was an interesting case because there was a large dysplasia here, and they wanted to try and do motor sparing surgery. So we did stereo EEG, and each of the electrodes was then looked at for genetic material from it. And we found that there was PIK3CA expression in the abnormal area. And interestingly, there was a difference in the amount of expression of the PIK3CA variant in different parts of the brain. So this patient had each of the electrodes looked at, and we found that the more anterior area, which is more abnormal areas, had more PIK3CA expression. And this is in this paper, which is recently published in Neurology Genetics. And we showed that there is a correlation between the phenotype and the somatic expression of the gene. This patient had a frontal disconnection with motor sparing and is doing really well. Newer detection techniques for FCD include things like MP2 range imaging for age-enhanced brain deco imaging. This is, for example, this patient had a subtle dysplasia here in the in the right superior temporal gyrus. Lateral here, you can see the gray-white differentiation a bit blurred on the flare compared to the other side, and same thing on the edge images. You can see nice T1 contrast here, and you can see a very subtle change in the gray-white differentiation. The gray matter is slightly more abnormal, and this patient had a mild, what's called MOGA, a mild malformation cortical development with the oligodendroglial hyperplasia, MOGHE, a new entity described recently. On PET, there was hypermetabolism as well. So here's the lesion again. So let's go to 7 Tesla imaging. Now we're using 7 Tesla in some of the patients who are eligible for this. This patient, for example, is a 15-year-old patient with a subtle dysplasia here in the precentral gyrus and supplementary motor area. You can see subtle blurring, which in 7 Tesla imaging, you can see a little bit better on the T1 weighted images. This is again, an edge sequence derived from the MP-NRAGE sequence, which gives you multiple T1 contrasts and allows for T1 mapping. A stereo EEG was done, and this area was shown to be very active, but the patient wanted to preserve function, motor function, so we could not go ahead and resect it. So this patient is still on medications. So we've talked about some of the advances in imaging and how it correlates to the new era of stereo EEG and very focused surgery. And as we go along, we want to get more optimized imaging protocols, develop more better motion correction images in pediatric patients. And we are now giving dedicated time slots where we can image one part of the brain for a long time and really get high resolution imaging of any area that is involved, that we suspect is involved from seizures. And the better signal to noise ratio on the 7 Tesla scanners with improved coils and motion correction. And then we have some newer tools like surface-based morphometry, connectivity analysis that we're working on, T1 mapping, and of course some machine learning, which is soon will be published. Some of our work on this, as other groups are doing around the world. Hopefully you have gained an understanding of the need for improved imaging in patients with pediatric epilepsy in the stereo EEG era. Thank you very much.